Good morning, everyone. My name is France Donnet. I work on maternal health at the Gates Foundation, and I'm very pleased to be here and to celebrate with you the end of POPPHI and the beginning of a new initiatives. I think those initiatives on PPH were extremely successful in bringing together the many agencies and individuals, experts who are working on postpartum hemorrhage. The foundation is quite active on postpartum hemorrhage as well, and we have been supporting different projects related to oxytocin and misoprostol as well, and we will continue to do so. I just wanted one word on the foundation. Just wanted to mention that we have posted all our strategies on the website as of yesterday, so I invite you to go to the website to look at the MNCH strategy or other strategies from the foundation. So we have a very interesting panel this morning. We have people from experts from Bangladesh, Ghana, and Mali. So we will begin with Professor. Professor Shah Moni Hussain, who is the Director General of Health Services in the Ministry of Health and Family Welfare in Bangladesh, is in the room. The presentation will be made by Dr. Abu Jamil Faisel, who is the project director of the Mayer Hashi project and works for gender health in Bangladesh. Then we will have Dr. Gloria Asare, who is the director of the Family Health Division and Reproductive Health, Family Planning, Child Health and Nutrition in the Ghana Health Services. And finally, we have Dr. Bina Keita, who is the Director of Reproductive Health in the Mali Ministry of Health. She will present in French, but her presentation, her slides are in English. So I guess you will be able to follow her presentation. So without further ado, Dr. Jamil, can you come to the stage?
Good morning. On behalf of the team from Bangladesh, Professor Hussain, who is the Director General of the DG Health, Health Services, and myself, we will be presenting the national impact of the PPH prevention in the Bangladesh. And this is an experience where both the government and the non-governmental organizations, professional bodies have been working together. This is just to give you a background of the situation, the maternal health situation. Just to point out that 85% of the deliveries occur at home. And so a large number of deliveries are occurring at home. And the percentages of women who are delivering at the facilities, of them, only 16% they are provided with AMTSL. So the AMTSL at the service facility is not practiced properly. And that's again is out of an assessment we did in 2008. In spite of that grim situation of the maternal health in Bangladesh, there is a strategy there in Bangladesh which was developed in 2001 with all those components. And in that one, there had been a lot of emphasis on emergency obstetric care, antenatal care, skilled birth attendants. I mean, government has been paying a lot of attention to this particular specific intervention, because as I have mentioned earlier, that 85% of the births occur at homes. And so is postnatal care and family planning. And family planning in Bangladesh has been given a strong emphasis, and for that we have a separate wing who provides the family planning services. Besides those which are already spelled out in the national strategy, some evidence-based practices already have been initiated in Bangladesh, like the active management of the third stage of labor, use of Maxal for the prevention and treatment of eclampsia and preeclampsia. I would specifically now touch upon the PPH prevention. I have a couple of slides. Just to give a scenario that how we initiated and how we are actually progressing. A large national stakeholders meeting was held back in October 2006 with the funding support from POPPHI. And then the PPH task force was was actually formed with the Director General of Health Services in the leadership. The national assessment on AMTSL was initiated, and then we completed this in 2008, because all the professors, all the teachers of the medical colleges, and also the providers, they keep on saying that AMTSL is being practiced. And AMTSL, we all know about it. This is so simple. But then, we said that, okay, let's pick up the evidence, what is being actually done in the field. And that's the evidence. The 16% in the facilities, 16% of the mothers do receive AMTSL. In May 2008, the misoprostol, the use of misoprostol, was the tablet itself was re-registered by the Director of Drug Administration for PPH prevention. This drug had been available in the country as an anti-gastric ulcer treatment drug. Then the government, in August 2008, approved a guideline, an implementation plan for piloting misoprostol distribution and use at the community level. So these are the kind of the milestones in the PPH prevention. And based on those, the final thing which I mentioned in the earlier slide, that after the guideline that was developed and approved by the government, we, Engender Health, in collaboration with the government, along with other NGOs, we initiated a two-pronged approach. One, providing AMTSL training to the facility maternity service providers, and these are the numbers which we have done so far in 25 districts. By the way, Bangladesh has 64 districts, so we could cover 25 districts. In the next slide, I would show that some other organizations are also working on it. And then the second prong was at the community level. We initiated the use of misoprostol drug for the home deliveries. And for that, there had been a lot of trainings, development of BCC materials, and conducting BCC activities for community awareness. And then finally, in 3 districts, we are into it. That's the slide, the map of Bangladesh. On the left-hand side is the AMTSL training, as I mentioned, that we did in 25 districts. The OBGYN Society, OGSB, they did in 5 districts, and UNFPA, they conducted in 4 districts. So it's about 34 districts. Half of the country has been covered with AMTSL training. On the other hand, on the other side is the misoprostol use, showing in the districts where the misoprostol have been initiated. We are doing in 3 districts. ICD-DRB is in 1 district, and BRAC, as you might know, is one of the largest NGO in the world. They are working in the urban areas of 1 district and in rural areas of 4 districts. Our experience, experience of misoprostol use in 1 district. This is a district by the name Tangail, and there we actually started in late November 2008, and then ended the pilot in June 2009. We actually registered about 20,000 women, pregnant women. Of those, half of them, they delivered at home and where they received the misoprostol tablet. And of those 10,000 women, 9,228 actually used misoprostol. They took misoprostol right after the delivery of the baby. There are some common reasons for not taking misoprostol. Most of the women have some misperceptions. They were so severely anemic, they believe that they don't have any blood to lose. Women who took the misoprostol tablet then left the working area, because there is a custom in Bangladesh that the women, they go and deliver the babies at their mother's home. So they left the working area where we have been working, and then went and back to their place, and then forgot to take the drug with them. Women who delivered alone at home, they forgot to take the drug sometimes. Some lessons learned. AMTSL is practiced by trained maternity service providers, but not consistently reported. As you might have seen in DEVs, that 88% have been reporting. So practice and documentation need to go hand in hand. Evidence from 2 districts shows that AMTSL is reducing the incidence of PPH, and I'm sure Darcy would be telling more of it. Misoprostol can be safely distributed by the government and NGO field workers. That's what we have been piloting, that to distribute by using the existing channels. I mean, we were not creating different channels of distribution, and that is possible, but additional distribution channels need to be found out to enlarge the coverage, because we could not cover all the pregnant women in that area. The misoprostol pilot has encouraged the government and the PPH task force to implement other evidence-based interventions. I mean, a lot of other evidence-based interventions, simple interventions are now being discussed, and hopefully government would be taking up action. Interventions have shown that importance of strong government commitment and active participation together with detailed monitoring to achieve success. Yes, I'm just at the end. I have only one more slide. These are the challenges. Injection oxytocin at the facility level, I mean, that's not available all the time. And again, proper storage of the injection oxytocin is a big issue. Misoprostol is not yet included in the essential drug list. We are all advocating for that. AMTSL and misoprostol are not included in the government MIS system. Today, this morning, the DG was speaking, and he was mentioning that the MIS has to be strengthened further to include all of the reporting of these particular interventions. Lack of supervision, on-site coaching, that's an inherent kind of a situation, and that's a big challenge. Public sector has a lot of inherent issues like vacancies. Providers are not available at the places. The National Strategy for Maternal Health 2001, that needs to be updated, and government has actually started working on it, and that's the end of it. Thank you very much.
Thank you very much, Dr. Jamil. We will take the questions at the end, so the 3 presentations first. So, Dr. Gloria.
Sit down. Sit down.
Okay.
Sit down.
I'll sit down here because they can see it.
Just go ahead. Yeah. Do you want me to go again? Pardon? Are you ready? Yeah. There you go. Thank you. Good morning. I'm going to present the multiple ways to scale up PPH prevention in Ghana. The outline will be, I'll give a little background on the maternal health status, maternal deaths, and then we'll go into the current strategies, AMTSL, misoprostol, some researches, and the way forward. Ghana is situated in West Africa. We have a population of 23 million now. It was 20 million at the last census. We are expecting a census next year. We have a total fertility rate of 4%. Unmet need of family planning 35%, and the contraceptive prevalence rate of 17%, which is low. Maternal health, we are having improvements in antenatal care, super skill delivery, and then we are trying to reduce TBA deliveries. We can see here that they are all on increasing trend except the TBA deliveries. By region, we have 10 regions, administrative regions in Ghana, shown here, and then we have the 59% skill delivery by doctors, nurses, midwives, or auxiliary midwives. Causes of maternal deaths. Our maternal mortality ratio is 451 per 100,000 live births. In the latest survey was in 2007. Hemorrhage is the biggest contributor to maternal deaths, accounting for 24%, followed by abortion and hypertensive disorders. We have challenges, and we talk about the 3 delays. The first delay is a delay in seeking care. People are unaware of danger signs. The second delay is the delay in getting to the reaching the health facility or someone who can help. And the third delay is once they are in the health facility, receiving adequate care is usually not there. So we have these 3 delays that we have to work on. And we also have policies, strategies to deal with maternal and neonatal health, as well as child health. So prevention of PPH, we have current strategies in several areas outlined here. And under policy, we have registered misoprostol as for obstetric and gynecological use in Ghana with the Food and Drugs Board. We also have it on the essential medicines list, as Debbie has already told us. Then we have our guidelines revised. Our safe motherhood protocols have been revised to make the practice of AMTSL up to date. Now, with training, we've had pre-service and in-service training, as Debbie has already said, and we had the groundbreaking research on AMTSL, which gave us all a shock that we're having a 3% practice. We had oxytocin almost everywhere, but the rubbing of the uterus was what we were having a problem with. So we ended up with 3%, which was a big shame, and we decided to work hard on it. So specific partnerships with POPPHI. We have the AMTSL survey, which we've mentioned again, and then what happened is that after the strong advocacy to reduce PPH and some action in specified facilities, the repeat survey has shown a 9-fold increase from 3% to 27%. We've had the dissemination meetings of the results. We have changed the definition to comply with WHO standards in our ICM WHO FIGO standards in our updated safe motherhood guidelines. And we've had a provider, in terms of provider practice, site and individual training in AMTSL in 6 hospitals in 2 regions. That's the Western and the Eastern region, where the regional directors also came up and wanted the help. So POPPHI was there to help us to do that. The staff were updated with the site and individual training, and then they had mentors. After self-directed learning, they came for clinical practicum, and this has assisted doctor midwife teams to practice AMTSL, and this has also proven to be very cost-effective. Then we have the changing AMTSL behaviors in obstetrics, CAMBU, which we will have a presentation on, and this was in the 2 main teaching hospitals where staff, respected colleagues, worked on increasing the use of AMTSL, included the components in the delivery and delivery log and the pathograph chart, and this has significantly increased the use of AMTSL from 11% in the first minute. 11% in the first minute, it increased to 20%, and then 28% in the third minute. Having oxytocin has increased to 36%. We'll have more on that in another presentation. With regards to drugs and logistics, we've had a major initiative with procurement, and we've worked together with the pharmacy division, the central medical stores, to come up with how we will procure, store, and manage oxytocin and other uterotonics. With regard to monitoring and evaluation, they've been included. AMTSL has been included in supervisory tools, and these are technical supervisory tools which we are using. And Kolebu and Komfanochi teaching hospitals have incorporated these in their logs, as we've already mentioned. We have researches on misoprostol for prevention of PPH going on. Venture strategy is going to 3 districts in 3 regions, Brong Ahafo, Eastern and Central region. And antenatal clients will be counseled and provided with misoprostol to be taken after delivery of the baby, in case they deliver at home. And there's going to be community sensitization with that. Then we have the Millennium Villages project in Ashanti region, in a district in the Ashanti region, where antenatal clients again will be counseled like in the other project. And there'll also be community sensitization, but they have community health extension workers. These are the CHUs, to link up home deliveries with the community health officers. These are nurses, professional nurses, who are in the what we call CHIPS, community-based health and planning services. We have compounds in the primary care level. So they are going to work together. And with this, they are also going to measure the blood loss with a special drip to look at whether we are going to measure the incidence of PPH. We are all noting here that misoprostol will not be handled by the traditional birth attendants or the CHUs. They will be given to the women. So our way forward is to, in terms of PPH, is to disseminate our newly reviewed safe motherhood protocols and continue with in-service training. And we need to improve on monitoring and supervision and have more partnership with private providers, disseminate research findings, and scale up best practices. We are also looking for appropriate ways of introduction of the Uniject oxytocin. Then we have general way forward for maternal health in general, which includes partnerships with civil society organizations, repositioning family planning, training in midwifery, and then maternal death reviews, including confidential inquiry, procurement issues, improvement of availability of cesarean section, blood transfusion, and then improving communication and strengthening adolescent health and development services. These are some of the things we intend to do. We thank you for your interest in Ghana and the attention that we've received in Ghana and for listening to me here. We acknowledge, yes, we acknowledge the support of all the partners, and we are looking forward to support to move this forward. We are at a very critical point, and we hope that we'll get more support to move AMTSL forward from anywhere that we'll get. Thank you very much.
Thank you, Dr. Gloria. Dr. Binta, vous venez ici.
Non, je pense que c'est un non. C'est déjà, regarde, c'est en anglais. Okay, no problem.
The video is right here.
After I put the video.
At the end.
After. D'accord. Ici. Merci.
Okay, so the discussion is: do you want the interpretation, or do you think that you can manage with the slides in with the slides in English and she presented in French? Is that okay? Anybody wants interpretation? Who wants interpretation? Just a few people. So we're gonna proceed. So no interpretation. I'm sorry. So she will speak, and you can ask question if you. We can have a question and answer session at the end. So okay,
I'm sorry. I'm not interpreting.
No. Not now. Not now.
Merci, Madame la Présidente, chers participants. Je ne pourrais commencer sans remercier le gouvernement américain et remercier l'USAID et tous les partenaires techniques et financiers ici présents qui sont impliqués dans la santé maternelle au Mali. Et je remercie Deborah, Armbruster et son équipe. Je pense que vous êtes des champions en matière de hémorragie du postpartum. Je remercie Souchela qui n'est pas là. Souchela, elle devait être là parce qu'elle a beaucoup fait au Mali. C'est elle qui a accompagné l'équipe du Mali. Tous nos remerciements. D'accord. Je vais vous présenter l'engagement national à la mise en œuvre de la GATPA, l'expérience du Mali après les différents tests. Ça, on fait l'économie quand même de la carte du Mali, comme on n'a pas suffisamment de temps, et avec les pays limitrophes. Et nous avons introduit la GATPA au Mali en 2002-2003. Il y a eu les sites pilotes et la faisabilité. Ensuite, après les sites pilotes, on avait formé les sages-femmes, les infirmières obstétriciennes et les médecins et qui faisaient les accouchements dans les structures. C'était le personnel qualifié. Et ensuite, en ce moment, en 2001, avec l'EDS, il y a 45,3% des accouchements par voie basse qui étaient faits par les matrones dans mon pays. Et les matrones n'avaient pas commencé à utiliser l'ocytocine pour la pratique de la GATPA. Mais après l'étude chez les personnels qualifiés, on a mené une recherche opérationnelle avec l'équipe de POPPHI et il y a eu une évaluation de base. Et ensuite il y a eu l'intervention. Après l'intervention, il y a eu l'évaluation et le monitorage de l'intervention de la GATPA chez les matrons. Et les résultats de cette étude ont montré que les matrones pourraient appliquer la GATPA avec compétence et sécurité. Lorsque les matrones appliquent la GATPA, la couverture en GATPA peut atteindre 100%. Et quand cette étude a été faite, les résultats ont été restitués au niveau de la Direction nationale de la santé. Ensuite, nous avons vu que c'était très utile, comme on a des problèmes de personnel qualifié, comme c'est les matrones qui font les choses. Quand ça a été présenté au staff du ministre de la Santé, il a toujours tout de suite adhéré parce que les matrones n'utilisaient pas l'ocytocine chez nous. Donc, il a instruit à ce que la GATPA soit pratiquée par les matrones au Mali. Et en ce moment, il y a eu une décision. On a mis en place un comité national de suivi de la GATPA. Ensuite, nous avons développé un plan d'action national où tous les intervenants en matière de la santé de la mère et de l'enfant interviennent. Ils se sont inscrits dans le plan d'action. Et on a le suivi de ce plan d'action. Et le ministre en a fait aussi une communication écrite de la GATPA. Et ensuite, il y a eu des interventions de certains prestataires. Je veux passer l'intervention des prestataires. Si vous pouvez me placer ça. Où est Frichir? Viens me mettre ça. Donc, vraiment, nous avons vu que quand les matrones sont très bien formées, il faut me mettre ça, quand les matrones sont très bien formées, elles peuvent avoir 100% de couverture en GATPA en même temps que le personnel qualifié. Je voudrais passer l'interview des prestataires. Celle-là, c'est une matrone qui fait l'interview, qui dit que depuis qu'ils ont commencé la GATPA, quand même, les hémorragies ont diminué. C'est une matrone de la place, parce que quand on dit que les matrones font la GATPA, les gens disent, mais ce n'est pas le personnel qualifié. Je pense que chez nous, les matrones ont un certain niveau. C'est les gens qui ont le niveau BPC et ensuite, ils ont fait des formations de 3 à 4 ans. Ils peuvent bien pratiquer la GATPA. Elle dit qu'il y a des fois, le décollement du placenta était très, très difficile, mais avec la GATPA, vraiment, le placenta se décolle facilement. C'est ce qu'elle est en train de dire dans l'interview. Je ne sais pas si l'interprète va le dire après. Ça, c'est une matrone. Hein? Oui, voilà.
Très bien, parce que c'est écrit.
Voilà, si c'est écrit, on comprend. C'est une matrone. Je pense que la traduction est là. Voilà. Parce qu'elle dit qu'elle a saigné, elle n'a pas beaucoup saigné. Bon, lui, c'est un chef de division santé dans un district. Aussi, on l'a interviewé.
la prise en compte des matrones très
Je pense qu'ils vont comprendre.
quand on regarde sur
Vous avez encore d'autres...
Non, après je remercie, c'est tout, c'est pas beaucoup.
environ 80 à 90% des accouchements sont effectués par les matrones. Donc, si nous voulons vraiment diminuer les hémorragies du postpartum et diminuer la mortalité maternelle et néonatale, donc il faut prendre en compte les matrones dans l'application de ces stratégies. Donc, si nous arrivons à prendre les matrones en charge, à les encadrer efficacement, je pense que les objectifs assignés à la CAPA seront atteints.
Bon, je tenais quand même à partager ces interviews avec vous. Et dans le discours de Deborah, elle a parlé de l'intégration GATPA, soins essentiels aux nouveau-nés. Nous l'avons fait au Mali. Quand on fait les formations, on intègre les soins essentiels aux nouveau-nés à la GATPA au Mali. Merci. Il faut arrêter maintenant.
So the last comment was about including neonatal care with AMTSL. You understood that? Okay, so we're going to have questions. I think we have 10 to 15 minutes for questions, and I will ask you to help if there is a question to Dr. Binta. Questions, comments, clarifications? Stacy, yes? You have a mic. You have a mic coming.
Check.
It's probably on.
Thank you all for your wonderful presentations. Hi, Gloria.
Hold the mic closer.
Closer, okay. Gloria and I got stuck in the mud out visiting sites last April in the rains. We were showing her how women can't get from homes during rainy season to the hospitals, and we had a real experience. I'm involved in this Millennium Villages project as one of the PIs, and one of the things that I want to point out, which Gloria talked about, which I think is so critical, is this idea of being able to very carefully monitor the safe and appropriate use of misoprostol. I don't think we're going to change the minds of some of our international policy partners unless we can very clearly show that we have good data showing it can and will be appropriately and safely used for the purposes that we are distributing it. So this is, many of you have heard me say this before, but I just want to reinforce it.
Thank you, Stacy. Indira? Yeah. Anybody else?
Thank you. I'd like to congratulate the speakers, and I know how hard they've worked in their countries, not only on the presentation, but the wonderful work that they've done in their countries. I'd just like to follow up on what Deb and Binta said, is this integration of AMTSL with newborn care. The two are so closely related, and if one doesn't focus on that integration, one tends to actually neglect one of them, because you have such intense work going on for both the components, and they literally are competing with each other at that time. I'm happy to say, as Deb remarked, Basics and POPPHI have worked together to develop tools for training for facility level workers, which are quite in-depth, with a reference manual, a guide for trainers, checklists, both learning and evaluation, participants guide. We've also got all the presentations in PowerPoint, and these are now on the website of Basics and will shortly get onto the POPPHI website. We've got some also for the community health workers tools, not the AMTSL because some of the countries did not accept it going readily into it, but the rest of the components integration is there. And we've also got the monitoring and evaluation tools. One or two are still going on, and I think Thanksgiving has interfered with the complete installation, and they will get up on the web soon after, and will also be taken up on the POPPHI website. Thank you.
Thank you. Thank you. Beverly, the last row, Beverly Winikoff. Then the last row.
Thank you very much
hold the mic closer. No, it's not on.
Thanks. Yeah. Thanks for these wonderful presentations and for the really impressive proof of concept that you can mobilize and make these projects occur. I have a question about understanding what they do, because I think that some of the evaluation tools are only getting at process indicators and, if I understood correctly from the presentations, and also to some degree measuring blood. But one question that we as a community have never answered yet is whether such a scale-up actually saves lives and or resources or morbidity. And I'm wondering if any of these projects is going to be able to answer that question, because from the information we have now, we could be in a situation where governments are spending money on large-scale programs to reduce the average blood loss in pregnancy of an ounce or two, with no impact on morbidity and mortality, at least that we can show. So I'm wondering if anybody is going to have any information on those issues.
Okay, so I will ask the panelists to address this question, or anybody else in the audience. You want to start,
Sure.
Dr. Jamil? Yeah.
The work which we are doing in one of the districts, the numbers which I have presented, that 10,000 women, in those 10,000 women, 92% of the women, they did take the misoprostol tablet, and there were, among these 10,000 women, there were 3 deaths. And so we do have numbers available, the statistics available of deaths as well. Those 3 deaths, one of the deaths occurred that the woman was not allowed to take the tablet because she was so anemic, and her in-laws were all telling that you don't have any blood to lose. But ultimately, the women died due to blood loss. The other 2 also had similar kind of situation. So I think we are also keeping a track of the women, those who are having morbid conditions after the use of the tablets. There are information available with us that whatever the side effects, whatever the reactions after taking the tablets, and also the deaths. And at the last, we are also having a third-party evaluation of the work which we have done in this one district. So we would be having more information available on the impact as well.
Thank you. Dr. Gloria Asare?
Yeah. Thank you. Thank you very much. Yes, the prevention of PPH, we measure routinely in our service delivery what proportion have PPH and the deaths. So we have that information. Some facilities have now had a reversal in the causes of maternal mortality from PPH to eclampsia. So it shows that something has been done about PPH, and now we need to also do something about eclampsia. So we are measuring it. And the study in Ashanti region is going to measure the incidence of PPH using the drip. So we are measuring it. Thank you.
May I just add, we're also looking at transfer rates, need for additional uterotonic surgeries, a lot of the other morbidities.
Okay. Nancy? Yes. You can introduce yourself and your affiliation. I forgot to ask the other people.
I'm Nancy
to
Sloan.
do that.
I work with everybody. I'm with Apt Associates, and I work with Genuity Health Projects. I'm an independent consultant, and with Columbia University. I had a question for the project in Ghana that you had mentioned, that you were giving the misoprostol directly to women and not to the TBAs or the community health workers. Could you, is that going to be discussed further in another presentation, or could you discuss it now?
Okay, go ahead. Yes, thank you. We had a lot of debate about the community health extension workers. Actually, misoprostol, people in Ghana know about misoprostol, and they are using it for abortion. They are using it for inducing abortion. And these community health extension workers are young girls. And we didn't want to give them loads of misoprostol to be given to other people. We have, with PMTCT, we give the women nevirapine and they are able to use it. So with the same concept, we are going to give it to the women themselves. We also want to encourage the TBAs to bring the women to the facilities. So we don't want to be stocking them up with misoprostol and other things. We are reorienting them to work in neonatal health. That is. Yes, it will be checked. This project has not fully started. We are in the process of, but this is all in the protocol. We'll give it to the women, and when they come for postpartum, we will check whether they took it. And some of them may come to the facility. So if they are delivering in the facility, the midwife will collect the misoprostol from them. So we have mechanisms, and we hope we can do that.
Thank you. If there are no other Fernando, can you introduce yourself? The last question.
Thank you. One question.
Introduce yourself, please.
Yes, Fernando Altave from Buenos Aires, Argentina. So very, very interesting presentations, the three of you. One question to you is that, do you think that, let's say, or are you taking, let's say, provisions to be sure that it is safe to give the women, let's say, misoprostol during pregnancy just to be used at PPA, let's say, at postpartum, let's say, directly given the women without any kind, let's say, of research to be sure about the safety of that measure?
Okay, this is the research we are doing. We have misoprostol in our protocols for community level use, and the women will be counseled and told specifically. The TBAs will also be given a sensitization, so that they have to check after the baby is born that there is no other baby in the uterus before they give it out, and they will call the community health extension workers or the community health officers when there is a delivery, so that they also try and be there. So we are trying to operationalize this in the research, and then we can scale it up.
Okay, Dr. Jamil, last word.
I just wanted to add to what she said. In our scale up, I mean, in one of these districts from where I had presented the data, we did do a follow up, and 82% of the women, they were followed up. We told them to keep the strips of the tablet, the used strips, and the catch cover, and those were recovered from 82% of those women. And the information which we have gathered, that none of these 10,000 women had any, I mean, they didn't take it in properly before the delivery, or, I mean, during the period when they were given and up to the delivery of the baby. So there were no mishaps. All these women, these are illiterate women. They were counseled. Their in-laws were counseled. They were given a small card to remember the steps. And so we didn't find any mishap occurring in those 10,000 women.
Thank you very much. A big round of applause to the panelists.